Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Seminars brought to you by Triple N Media YouTube channel, where we have more than 200 cardiology lectures, and we welcome you to watch them. I also kindly request you to please do subscribe to our YouTube channel, and I will tell you how you can get a free copy of my Cardiology Rotations Manual at the end of this presentation. The feature presentation today is on vasopressors, inotropes, chronotropes, and much more. Whenever we are dealing with a patient with a shock, first thing we need to do is establish the etiology of shock. Shock can be due to a variety of conditions like hypovolemic shock, cardiogenic shock, could be obstructive in nature, or it could be distributive. I have a separate chapter on cardiogenic shock. You're welcome to watch that. And let's talk about hypovolemic. There is reduction in the intravascular volume. When I say reduction in the intravascular volume, that's something you need to focus upon, because the patient may have edema, the patient may be extracellularly volume overloaded, but there is reduction in the intravascular volume. Aggressive diuresis can lead to intravascular volume depletion. Similarly, hemorrhage, emesis, diarrhea, burns, and polyuria are some of these conditions that can lead to reduction in the intravascular volume. When there is reduction in the intravascular volume, the venous return to the left heart is reduced. When the left ventricular end diastolic volume is reduced, the stroke volume is reduced, which leads to reduction in cardiac output and hypotension. So that's the hemodynamic basis of reduction in blood pressure in patients with reduced intravascular volume from any cause. Cardiogenic shock, on the other hand, is reduction in the left ventricular pumping function. There is an extensive myocardial infarction. There is damage to the myocardium, leading to inability of the ventricle to squeeze. So we have a systolic pump failure. We may see that in patients with cardiomyopathy, infiltrative cardiomyopathy, or patients with severe aortic stenosis or severe mitral regurgitation, or it could be related to arrhythmias. What happens during arrhythmias is there is reduction in the diastolic filling phase. That means because of the rapid heartbeat, the only thing that shortens is the diastolic phase. That's the time during which the heart fills. When there is reduction in the diastolic phase, less blood is returning to the heart, and when there is less blood in the left ventricular cavity at the end of diastole, the stroke volume is going to be less. Combine that with tachycardia, you are going to develop hypotension. So it is myocardial contractility and also the heart rate. That's why patients with atrial fibrillation with rapid ventricular response can develop hypotension or shock. And in patients with valvular heart disease like aortic stenosis, or patients with hypertrophic cardiomyopathy can develop heart failure or hypotension quickly if they go into atrial fibrillation, because one, they are losing the atrial contraction, which contributes to 20 to 40% of the stroke volume, and also the rapid rate. Obstructive conditions like pneumothorax, pulmonary embolism, air embolism, cardiac tamponade. I have a whole separate chapter on pericardial tamponade, and you can watch that. Aortic dissection. I have a separate video on aortic dissection, the various types of dissection and how it can lead to bleeding and hypotension. Distributive. Anaphylactic shock. Anaphylactic shock produces profound vasodilatation all across the body. It has nothing to do with the volume. I mean, of course, the intravascular volume is going to decrease because of increased vascular capacity. Neurogenic shock is the same thing. There is sudden vasodilatation throughout the body, leading to drop in blood pressure, creating shock. Sepsis, we have a similar situation because of vasodilatation. the treatment for there is not something that you want to increase their contractility. It is not something you want to increase their heart rate. Here you want to cause peripheral vasoconstriction. Keeping that in mind, there are a number of drugs available. This is just a partial list. I'll have a separate video on vasopressors and inotropes in the next session. But let's talk about what drug do you choose depends upon what is the underlying condition. In patients with heart failure, in patients with myocardial infarction, where you have a primary problem with the contractility of the ventricle, you want something that would increase the cardiac output. So the drug you would choose would be something like dobutamine or milrinone. Whereas on the other hand, if you are looking at pure alpha stimulation to increase the peripheral vascular resistance, to cause vasoconstriction in patients with distributive shock, septic shock, or neurogenic shock, you prefer a drug that is purely increasing the systemic vascular resistance. Dobutamine has less effect in increasing the systemic vascular resistance, whereas phenylephrine or norepinephrine predominantly increase the systemic vascular resistance. Hence, understanding the underlying pathophysiology is of great significance in choosing the drugs or a combination of drugs in patients with shock to optimize their blood pressure, to optimize their peripheral circulation, to optimize their urine output, and minimize any pulmonary complications. Here's another chart, which is like a 2x2 chart. So if you are looking for an inotrope, then look at drugs like dobutamine and milrinone. If you want inotrope with a vasoconstrictive property, somebody who has a pump problem like heart failure, but also has vasodilatation, then you use drugs like norepinephrine, epinephrine, or dopamine. Whereas if you are dealing with a patient who does not need inotropic support, like the patient ventricular function is okay, but you're predominantly dealing with vasodilatation, predominantly looking for vasodilatation, then you use drugs like nitroglycerin, nitroprusside, or nicerotide, and these are used in patients with acute chest pain or ischemic heart disease, or patients who have hypertensive crisis or pulmonary hypertension. Whereas if you are purely looking for vasoconstriction with no need for an inotropic effect, you look at phenylephrine or vasopressin that is used in patients with distributive shock like sepsis or neurogenic shock. This is a quick summary of understanding the pathophysiology of shock and what happens during shock, what is wrong, and how we approach that. In the next presentation, I'm going to talk about each one of these drugs, the clinical indications, their site of action, their physiologic effects, dosage, and indications. I have a separate video on adrenergic, dopamine, and vasopressin receptors, where they are located, what they do, and how they are used in clinical situations at bedside, in the intensive care unit, or on the floor. Ladies and gentlemen, you have been watching Triple N Media. On our internet site, we have more than 200 cardiology lectures. You're welcome to watch those. And this has been a presentation of Triple N Media. If you would like to get a copy of my cardiology rotations manual, please do send me an email to drniknikam@gmail.com. It is in the description below there, and I will be happy to send you a copy of my cardiology rotation manual free. And please do subscribe to our YouTube channel. I will see you in the next video, where I'm going to talk about the vasopressors, inotropes, and chronotropes.